If you're wondering if short implants are still considered a compromise or if it's in fact a reliable option in implant dentistry, this episode is for you. Today I'm joined by Professor Ronald Jung from the University of Zurich, one of the most respected voices worldwide. Ronnie, what a pleasure to be with you again.
Thank you so much, Christian. I have to say, having a Pro Talk now with you is really, for me, something very special because you're an excellent moderator and I love exchanging you from a clinical point of view, scientific point of view. It's really always inspiring to talk to you. So thank you for having me here.
Oh, this is going to be a fun ride, I can tell already. Ronnie, let's start with the fundamentals. You've been studying short implants for a long time, and there are many definitions. If one is watching us today and they're curious because we have short, ultra short, mega short, extra short, what are the terms today and the fundamental terms that we learn about short implants?
I think today the talk is on a different level. I remember we had some years ago a talk about short implants, and I think today we are on a different level in terms of understanding. We had different phases. When I look back the last 15 to 20 years, there were one phase where short implants was just kind of something you were scared of.
Yeah.
Then there was a phase where you're very progressive. You really wanted to push how far you can go by pushing the limits in terms of biomechanics. And today, I can really say I feel very confident to give very clear clinical recommendation when it comes to short implants. So we know exactly where to use them. We also know exactly where not to use them. So today, I think things came together, and I feel relaxed by really giving good recommendation based on science, evidence, and also clinical experience.
And in terms of definition, is there a threshold where we say 6 millimeter, 5, 4? Do they have different names, or this is all short implants?
This is also kind of a transition which we had over many years. At one point, long ago, kind of 7, 8 millimeters were kind of considered short implants, and then we came to the 6 millimeter short implants issue, which still today is kind of what we talk primarily. But again, we want to have also tools available in clinics in order to go even further. And so today we have implants which have 4 millimeter lengths, which we had in the past as well, but they also kind of further developed, and they are now easier to use. And but again, with a limited case selection on the one hand, but also with a limited kind of evidence-based situation. But what I can say where we are very confident is when it comes to 6 millimeter implants and larger.
I see. So we should not get trapped with nomina or definitions, or it should be indication-based.
It should definitely be indication-based. There have been a variety of consensus conferences, also the ITI Consensus Conference, the one in Amsterdam in 2019, 18? Was it 18? Yes. That was kind of dedicated to these short implants. And there we have definitions. But today, again, this is now 8 years later, we have such a better understanding. And I really feel confidence today to give clinical recommendation when it comes to short implants.
I like this because short implants was perceived for many years as an alternative when augmentation either failed or it was not possible, never the first option. Is this the perception still today?
I think today it's all about case planning and case selection. And they should not be appeared as something when other treatment option didn't work out, that then the short implants should be part of. It starts actually today. In general, implant dentistry has changed dramatically because so much is going to be discussed with the patient and also assessed before the treatment starts. So looking back, doing this now for 30 years, the major change is that 30 years ago, 20 years ago, so many decisions have been taken during the surgical intervention. So it was much more stressful. It was much more a surgical discipline, implantology.
Yeah.
And today we have so many amazing tools available preoperative, which brings the patient, but also the dentist on a completely different level, what it means to feeling comfortable.
Right.
And I say that's so important today. I always say, when you sweat during a treatment, there are only two problems. Either your air conditioning doesn't work or you're working above your limits. And in this context, when I do a thorough planning I need to discuss with the patient what are the best options. And in this kind of options of tools, short implants are a part of this discussion before the patient starts.
I like how you put the patient in the center, but not but when I talk to some colleagues, for example, it's very common to have a discussion right off the bat, looking at an x-ray, and then you just speak from a 2D perspective. Oh, there's such an atrophy. That's not enough for an implant there. I should do augmentation. Do you think this is still how normally clinicians are perceiving, or we're going more from a restorative based approach, knowing what we know with the robust evidence short implants have?
I think even when I consider myself also slowly now to the older generation, but I think it's a generational issue. The dentist, kind of the older ones, again, they have been trained by really taking all decisions during the surgical intervention. And they're very capable of doing this, and they do this in a very excellent job. But when I look now at the younger generation, we have the privilege as a university professor to educate so many young dentists, also as the ITI president. This is one of our core businesses we are doing. There I can see this change of how the dentists really want to onboard the patient also from a communication point of view on a different level, including the dentist. So everything what we do in terms of prosthetic planning, in terms of implant planning before even starting any kind of invasive treatment, it brings not just the patient on a higher confidence level, but it also brings the dentist on a different level. And the young generation, this is much more natural, that they don't feel confident anymore just starting and then making decisions. And therefore, I do think it's just a question of time that this will be just the standard of care. And today, yes, I believe it should be the standard of care to go through a thorough prosthetic diagnostic procedure. And then based on that, the implant planning, including then whatever it's need from a regenerative point of view. And I also explain this to our patients. I always tell them it's like building a house. No architect would start digging a hole before you have not thoroughly discussed all the issues, where you want to have the balcony, where you want to have the entrance door, and so on. And this is the same thing here. We should not start any treatment before we do not exactly know what the patient actually wants in order to meet these expectations.
You brought up very nicely, like building a house. And we are wired to think, for example, like an architect. You will create a foundation of the house that is this big, and so the house can be very well supported. When we look at these restorations and x-rays where short implants are placed, it, 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 it makes you think differently, because what you look is not what you're normally in real life accustomed to see, like a bigger foundation with a shorter upper part. You're going to be looking at a very short foundation with a big upper part. Is that just assumption that things can go wrong? How can
Yes.
we overcome this?
I think that's, again, this is a generational issue. You and I, we grew up with implants, which you tried to even maybe place bicortically at that time.
Right.
And looking at this short implant, you think, oh my God, didn't they get a longer one there? So it's at the end, again, what you have learned and what you're used to. Today, again, for me, it's having a variety of tools available, and this is amazing. And then my job as a dentist today is to find the right tool for this patient. And some patients, yes, they do need, or they do want to have kind of more efforts in terms of restoring the alveolar bone and then being able to place longer implants. And others, they prefer to go for shorter implants. And you just need to find the right solution, the personalized solution, when we talk about personalized dentistry, for this individual patient.
Yeah. That's why research is so important, because if you just in a visual perception, it's very easy to fall in that trap of assumption.
Yes, exactly. And the research and the evidence-based, and also the way how we handle now, also with the ITI, to provide guidelines, it it takes away my personal opinion on this. It brings me more in an objective way.
Ronnie, I like to pick on not the researcher, but the clinician. Your choice. Ronnie, go to approach, right? You have a patient, let's see, a patient with a very limited vertical bone height. Let's pick one, upper or lower. Pick one now.
I think it's really different. Let's say lower.
All right. All right. You have a lower patient, very short availability. You have two options: a vertical augmentation. Now you put yourself in trouble. A vertical augmentation or a short implant. How would be your decision making and then your steps towards the case?
Yes, I love that question. Thank you so much, Christian, for that. Because whenever you're in a situation where it's not kind of clear in which direction you go to, make the patient being part of your team. Bring the patient on the eye level. Don't try to be the dentist and the patient. Try to be a team. Because then we talk about shared responsibilities. So in this situation, I bring the patient into the team. I also tell the patient, listen, I'm not your dentist and you're the patient. We are one team because we can only be successful together. And that means I provide you with all the information and we make a decision, a shared decision, a shared responsibility. What is the best option for you? And then I present the patient based on the diagnostic we have done. Obviously, this is the first step, as we discussed it before. We have a prosthetic diagnostic. We have then the bony situation based on the three-dimensional analysis and so on. And then I present the patient. Usually, we do it with 3 treatment options. And then I explain the patient the pros and cons. Let's say when we choose now a lower mandible, that means I presented what does it mean in terms of vertical augmentation, what effort does it mean, what also has it, what does it mean for the patient in terms of quality of life, what does it mean, what job the patient have, that it means for 1 week, I'm kind of compromised there because this goes along with the swelling because it was an invasive treatment. It goes along with the whole treatment time. It goes along also with the costs. And then I present alternatives with maybe some compromises having a longer crown, but with a less compromised situation when it comes to the surgical intervention and the invasiveness. And at the end of the day, we choose that option which fits to this patient in that age, in this profession, in this time of his or her life, what is the best option. And then when you do this, in this shared way of shared responsibility, you're never going to be wrong because it's a team approach.
Ooh, and that's an important decision, I would say, because it's very easy, for example, to say, well, I understand it's a team approach, but in the end, patients are not expert, right? They trust us with a path that will be more assertive. That's not an easy thing.
No, I wouldn't say so. I think, yes, there needs this true foundation of trust. But how do you gain this trust? You gain this trust by being transparent, by being inclusive also regarding the options. Because the trust is not gained through that I tell you, you need to have this type of implant. Because patients today are very well informed.
Yeah.
So you gain the trust by being knowledgeable, by being obviously experienced, and by being able to provide the patient with options. Because everyone likes to have options.
Right.
And when I can see we find together the option which fits to you in the best way possible, then this is then again, that is the foundation of trust, which helps you then throughout the entire treatment.
Ronnie, I like how you describe the path, right? You involve the patient in deciding the path with pros and cons. There might be a longer crown, there might be some morbidity on one side or the other. However, we get to an end result. Is there one that has a higher success survival rate than the other, or they're equivalent towards the end?
So you point out something very important because obviously when I argue in this way as I do, I need to have the backup of the evidence from that point of view. And again, now in 2026, we do have the evidence that in a situation where we have limited vertical bone, there are different studies, which we also have performed in Zurich. Some of them are large multi-center studies, comparing then the augmentation procedure versus the short implant. And from a long-term perspective, up to 10 years, we don't see a difference in terms of implant survival. However, when you start to compare short implants in areas which longer implants would be possible, then you have certain limitations. This is this famous study which we did very early ago. This is now more than 18 years ago. And this is the only true, I would say, honest study when it comes to the point, what is the influence of the implant length to the overall survival. And there we compared cases, upper and lower, where we can place a 10 millimeter implant, but we randomly choose then to either place a 10 or a 6 millimeter implant. And this was at that time, that was brutal, because you could theoretically place a 10 millimeter, but through the randomization, you have to place a 6 millimeter implant. And this study was very important in terms of to see whether we should in general just place short implants. And there we could see kind of limitations when it comes to a 10 millimeter implant. But when we only include limited bone augmentation, there with the comparison to larger vertical augmentations, upper or the sinus elevation procedure, lower, there we are very similar in terms of the implant survival and success rate.
And that's quite a relief.
Yes, absolutely.
Speaking of evidence, we have this section called It's Not What We Think, It's What We Know, exactly research-based. Is there any publication that you see that for Ronald Jung was really impactful in a way that Christian, it opened my eyes to see things in a different way, or it literally changed the way I do things based on this, either yours or from somebody else? Is there a piece of evidence you can bring up?
Yes, maybe there are three studies which really
love it.
significantly influenced my decision today, but also have influenced the ITI treatment guide when it comes to the recommendation of short implants or longer implants. One is the study which I just showed you before. This was essential to really compare only the implant lengths. This is the 10 versus the 6 millimeter implant comparison. That was a study which was very influential. There we could see we have very good long-term results with short implants. However, they're a little bit below a 10 millimeter implant.
Right.
So that was for me clear. When I can place a longer implant, I should place a longer implant. A second study was a multi-center study, which was only focusing on the upper jaw, because the upper jaw was always considered to be more difficult for short implants because of the more loose bony structure. And this was a multi-center study, which Daniel Thoma from my department was leading, comparing 6 millimeter implants versus sinus elevation procedures and longer implants. And this was a study with more than 100 implants involved in a randomized way. And there it turned out to be that we have excellent margin bone levels, excellent long-term results with both implants, the longer and the short ones. But there we also took the effort in order to look at the patient's invasiveness situation, in the economical situation, and also on the stress from the surgeons. And it's obvious that when it comes to the financial situation, it's 50% reduced. The invasiveness is more than 100% reduced, and also for the surgeons, also for me, which did so many sinus elevation procedures, it is a stressful procedure.
It is.
So this was an eye-opener because it brought in the economic situation and also the patient again as when we put the patient into the center. So we had questionnaire for the patient and we had questionnaire for the surgeons. And then there was another study, the third one, which I told you, which influenced my today's decision tree a lot. And this was one study where this was during this enthusiastic phase where we wanted to push the limits in terms of how far can you go with biomechanics. And there we compared in gaps where we have 2 missing teeth, 2 short implants versus 1 short implant, 6 millimeter, with a cantilever.
Right.
And there we did see this was too much. So we cannot push that much for a short implants, including then a cantilever for restoring in the posterior upper and lower jaw. So, and therefore today I can really say I'm confident in knowing exactly where are the possibilities, limitation. This is what I share with my patients in order to come to a comprehensive, thorough decision.
And do you see also a role of short implants in the full arch context?
Yes. So one thing which we also have learned is that from the moment on, short implants are kind of connected to other implants. That obviously increases their positive outcome from their point of view. But for instance, this was also important to mention the second study, this large multi-center study. There we, even when we could splint them, we did not splint them. So we really wanted to, again, having not too many co-founding factors. So there we have just used single crowns or multiple single crowns with short or longer implants there in order to eliminate that part. But if I can, yes, I splint the crowns.
That's even relieving to know that in single situations they perform really well. So it's fair to speculate that splinted it will work even better.
Exactly. That's a nice way to say it. Exactly. And this was the problem in the past, because that's what I once told you, comparing apples and bananas. Because in the past, it was actually unfair the way short implants have been analyzed. Because you have looked at large databases and compared, then pick out the short implants compared to the longer implants, and they always had a less good survival rate. Why? Because they have been placed in situations where we were desperate, where things maybe didn't work out, where you were just, I can get the short implants in and then trying to close my eyes and hope for the good. So that was not fair, because there you place short implant into very compromised situation, and the longer implant you placed into more convenient situations. So therefore, this comparison is not right.
I like this very much because it's a perfect segue to the next session that is called Experience Taught Me This. You mentioned about the sinus lifting, some vertical bone augmentation. But today, thanks to your experience hitting the wall so many times and making assertive or not as assertive decisions, today your backpack is quite full. So can you remember Ronnie Jung today reflecting on the younger Ronnie, some of the decisions that you say, I wish I knew then what I know now, or also in terms of medtech, I wish I had these tools at hand then that I would not have make that choice. Can you remember of one?
Yes. The one very emotional part, which I just told a couple of postgrads which I had last week, was there was in my entire 30 years of career, there was one single case which I could not complete. And this was a patient which I even knew, always like this. And he's a very nice patient. He has a tremendous resorption in the upper posterior area. And I tried to make the sinus elevation procedure. And I literally had a perforation. It became bigger and bigger and bigger. And it came really to a point where I didn't control it anymore. And that's another point where to be then self-confident enough to say, I cannot do this. Because you always think, okay, I cannot tell the patient that I was incapable of doing it. So at that time, but I really had to say, I need to stop. I need to refer to a more experienced dentist at that time and tell the patient about that, because you really feel ashamed. But I remember that also very well, how much the patient was saying thank you, to be so honest, to be so transparent, to say, listen, I didn't feel confident anymore to go further, and I would like to give you more experienced hands. At that time point, we didn't have the short implants available, so there I would have wished to have short implants to place the short implants at that time.
And that triggered the desire for the research behind.
I wouldn't go that far, but it was one among many triggers which came together.
Oh, that's a lovely story. And this other session, my favorite clinical approach. If you could give clinicians one practical recommendation, right? You just mentioned a few situations in which it was very humbling that you took that decision to tell the patient and say, well, this is as much as I can. And I know experience is untransferable. They have to live their experience to build their backpack as well. But if you could give practical recommendations using short implants, something that can truly make or break with such a sensitive, not sensitive, but we understand there's a technical sensitivity with the use of short implants. What would be that recommendation? Patient selection, surgical,
Yes, I can be
checkpoint.
very clear. So this is now one of my most favorite topics because that's also kind of a transition over years. When you're younger, you're very much into techniques, into surgical techniques, into also augmentation techniques, and so on. And the older you get, it's about the patient. It's about finding the best possible treatment for this individual patient. That I'm very passionate about. And that starts again from a completely different approach when it comes to the initial patient assessment, initial patient discussion, and bringing the patient into your team. That's for me the key issue. And the best thing, it reduces your stress. Because when I claim to make every decision by myself, giving the patient recommendation what to do, that's also all on my shoulders. So when things don't work out, then I'm also the one which has all the heavy
Right.
weight on the shoulders. It's so easy. Make the patient part of your team and make this shared responsibility. I'm gonna make one example which I love, which was a very prominent patient, and this patient had access to all possible dentists. And this patient was already at two very famous top KOL speakers, which we had at all the big conferences, which were excellent in terms of augmentation procedure. And I was also one among these three. So this person was circulating among these three, and technically they all could do everything in the most amazing way. They are endlessly experienced, but she stayed with me because I offered three different options. So that gave the person a much higher confidence. And I'm not better than the others, but I was just onboarding the patient in a very comprehensive and inclusive way. And then this patient could choose what is the best treatment for this individual situation regarding the age, regarding your professional situation, especially which was very much exposed
Mm.
internationally. So that was a decision to go for short implants. And I think that was again a wonderful example, which shows you need just to find the best possible solution for this patient.
You show that you care.
I'd care brutally, I would say. That's the beauty of our job because we have the privilege to treat the most prestigious in life, and this is the human being, the human
Yeah.
body, and we should do this in the best possible care. And this is the motivation every day going to work.
I love this very much. Ronnie, shifting gears a little bit, looking ahead, Straumann has had for a long time already the presence of the tissue level 4 millimeter. Now we're going to a new era, possibly by launching the TLX 4 millimeter. This could potentially open up for research, for more clinical indications, to minimize potential, as we said, technique sensitive issues during such a therapy. How do you see that potentially looking ahead?
Now I'm happy also to dig a little bit into that technical part because that's also what you mentioned before I was flying on a higher level, but I think it's important not to dive too early. But when we come now to the technical part, first and most important, placing a short implant is not per se a no-brainer because it needs skills in order to be able, because you have very little chance for to make it happen the right way because it's so short. You cannot compensate when you have when you're not the right angle and try to compensate there with a longer implant. You can do many more changes until you place the implant. With the short implant, you cannot. And when it goes to a 4 millimeter implant, it's even less.
Yeah.
So you have really one chance to do it right. That means from a point of view to assess the bony situation, to have ideally a guide to be really properly placed because you cannot do changes, and then also from the drill protocol because you cannot widen it too much because there is no chance to engage then. And I'm actually very happy to have the new 4 mm TLX implant, because it was challenging the 4 mm implant, the tissue level before, because yes, the threads were a little bit close together. However, it was still difficult to get it in place. And I think the TLX threads are ideal for that. You have a minimal augmentation and you have minimal osteotomy, and then you can use really this self-cutting kind of aggressive threads in order to get them into place. So that helped a lot to overcome some of the technical issues we had in the past with 4 mm implant. But it's also true for the 6 mm, obviously.
I like what you said, and I see with very good eyes the same way. It's important to rephrase that short implants are a viable option today at hand to spare patients from morbidity, either vertical augmentation that is far from simple, either sinus lifting. However, it should not be perceived, okay, now I have an option that I don't have to be equally as skilled. It's far from that. Then patient
That's
selection,
true.
proper planning, and be self-conscious of your experience.
Exactly. Exactly. No, this is definitely the case. Again, this comes back to the sweating part. It does reduce your stress while doing it. And just last week, as I told you, I had 9 Asian dentists from Thailand and from China, which were observing me during the surgical intervention in the afternoon. And funny enough, I had 2 patients. One was a patient which I know very long, which I took the tooth out, which has very limited vertical bone height, and I was doing a ridge preservation. And this patient received then in a flapless procedure a 6 mm DLX implant.
Yeah.
And then I had just the patient afterwards, very similar situation, similar age patient. The dentist has extracted 3 teeth in the posterior maxilla, hasn't done any ridge preservation, has let it kind of shrink and resorb, and I was needed to do a sinus elevation procedure. So for the young one, they enjoy obviously seeing me the sinus elevation procedure. I enjoy that as well, but it's not about me enjoying. It's not about the dentist what they like to do. It's about the invasiveness, because these 2 patients would have had the same chance to get to a less invasive procedure. One received it due to a proper planning, and the other one had to undergo a much more invasive and technique sensitive and stressful procedure.
Roni, sadly, our time is up. And I can only thank you very much for spending time, always clarifying, always so personal, so lively, and with tons of evidence behind. And to all of our colleagues who's watching us now, how they can find you, learn more about courses, research, platforms, ITI that you are directly involved.
Yes, so we are, as a university clinic, on one hand, we have a different kind of courses running throughout the entire year. Also, just this week, we have a 3-day course when it comes about more comprehensive implant treatments. And we are currently also running ITI courses, Straumann courses for, on the one hand, for beginners, but also now more a comprehensive one when it comes to edentulous jaws. So therefore, it's part of our DNA to really educate dentists. And when I put my hat on as a ITI president, for me, the biggest passion is to really try to provide more patients with better care. And we have just launched the kind of the kickoff of the ITI World Symposium, which will take place then in May 2027 in Milano. And I really aim to make this the biggest implant event ever in the history of dentistry. So this is, I think, the kickoff, and we share so much passion for it, and I really cannot be more excited for this event.
I'm really looking forward to it too. And about social platforms, there's also Roni Talks.
Yes, that's true. They have convinced me that I also should be should be present on social media, and together with the ITI in a very shared way, we have created a new Instagram account under my name, and it's also a lot of fun, because for me it's like an additional way to communicate with the people, which I have not used before, and we do this now not even for a year. It started last May, and I'm excited to do this, and it's a good way to exchange.
Instagram. Right?
Instagram, yes.
All right. Roni, as always.
Thank you so
Great
much.
pleasure.
Thank you so much. It was a true pleasure with you. You're really an amazing moderator.
Thank you. Thank you very much for your audience, and I look forward to seeing you in the next episode of Straumann ProTalk Clinical.